as you can see, Karen is just out of surgery and she's going back to surgery. So we've got an hour to maximize our questions and getting the answers that you need. Today, we are carrying on about cranial cruciate because we spent an hour last week talking about identification and management with a very conservative focus. Today, we're going to dive straight into surgery. And Karen's going to lead talking through the common surgical approaches and the pros and cons and where we're heading, etc. So take it away, Karen. Let's start.
Okay, so I guess where I'll start from is the same kind of perspective. If we have a client come in, we've gone through all that discussion we had last week, and they've decided that they do want to go down the surgical route, and I'm a big believer that as much as possible, without kind of flooding someone with information, they should know all of the options that are out there and available, at least the ones that I can offer. And then if there's something I think that's great and evidence-based that I can't offer, I will also tell them about that and give them options to kind of potentially go elsewhere if that's what they decide to do. So I'm lucky in that respect that I work in academia, so I'm not having to worry too much about whether I'm making profits or anything like that. I mean, my director would hate me saying that, but I don't have that kind of pressure to, if I feel someone can be better served elsewhere, then I don't have any pressure to keep them here. So I think that that's nice for me, which other people maybe have different pressures to work under. So from my perspective, I normally start off the conversation with them kind of saying, well, we have obviously two real schools of thought when it comes to managing cruciate disease. And one is trying to kind of put something in place that's going to act like the cruciate ligament, like replace the cruciate ligament, if you like. And then others are more mechanical techniques that are going to alter the mechanics of the joint such that the dog doesn't need a cruciate ligament anymore. So I normally split them up like that to start off with. Then in terms of a lot of people now have got obviously a lot of access to the internet. They've often done a lot of reading before they come in. And so I think, it's a bit dangerous to just skip over things that they might have come across online. Yes. So, and also a lot of people, like cruciate ligament injuries in people are super common as well. So I think like drawing the parallels there and showing the differences as to why we don't treat the same as in people can be important too. So I often start off with, well, obviously, if you've known anyone who's had a cruciate ligament injury, then you'll probably know that they do genuinely kind of put a graft or something in place that is going to replace the cruciate ligament. Genuinely, that's what they do in people. And I explained to them the reason why we don't really pursue that route in animals very commonly anymore. And that is because obviously several years ago, there was research performed that showed that if we did those intracapsular repairs, that dogs had a poorer outcome 6 months after surgery than if we did any of the other options. So really since that time, we've moved away from that technique. And I think that really just gives people a little bit more confidence in you that you're not just kind of doing your own thing, because to say everyone comes to the table with their own experience.
And I think it's fair to say at this point, there's quite a history of different techniques that have got us to where we've got. We haven't just gone, oh, look, we've found some ways.
Right.
A lot of like the fascia lata graft that you kind of come through, and there's lots of different things people have played with. So that finding that paper is quite a good, and we can put that to bed. Now let's try. Yeah.
Exactly. And I mean, there are still people out there doing those techniques, kind of older surgeons who have got very good at them. They're very confident that is what they do and that is what they get good results with. And that's fine. I'm not saying they all have to change what they do, but in terms of when we're training new surgeons to come up, that's not a technique that we really concentrate on training them in anymore, unless they're planning on going down to the research field and researching human injuries, in which case they will need to know how to do that, obviously. Okay. So one of those that we can kind of skip past a little bit, but Hannah's absolutely right. One of the questions I sometimes ask my residents when they say they've read the cruciate chapter in multiple books or they've researched cruciate disease is could they give me 50 ways of treating cruciate disease? Because actually there are 50 different ways out there, like ranging from injecting blood into the joint to transposition of the fibula head to skin grafts in the joint and all weird and wonderful things which have been done. So there's a huge amount out there, and distinguishing good from bad and from ugly can sometimes be a challenge.
Would it be fair to say that there still is this pursuit of the ultimate intervention? And you know, there's a lot of people working on this, and I'm going to be controversial. It's quite a lucrative pot of gold to find that way that will always work. So it's still developing, isn't it?
Right, and in multiple fields, right? So it's not just, I mean, yes, everyone's looking for this kind of the gold standard Cruciate technique that they can put their name behind and make millions. I mean, but I say everyone, I'm not, but yeah, there are certainly lots of people.
The Perry-Butler plate.
Can you imagine? PBP, no. But yeah, no, it's certainly a lot of people looking into it, but a lot of people looking into different routes forward as well. Like, can we genetically make this disease less common in some way, shape, or form, which is far less easy than it sounds. But can we start to breed out Cruciate disease, or at least make it less common? And that's certainly, people are looking at that too. Far brighter people than me, because genetics just blows my mind. But yeah, there are people working on that aspect of things. People working on, as you alluded to last time, is there an inflammatory focus somewhere, and can we get on top of the inflammation before this whole thing starts? So certainly lots of different avenues being researched all the time with this. So hopefully we'll only improve on where we are now. But yeah, so normally, start off the conversation with kind of just putting that intracapsular repair to bed, or at least explaining why we don't pursue that route ourselves. And then moving on then to kind of normally talking in quite a lot of depth with them about extracapsular stabilization techniques. Now, there are,
when
again,
you say extracapsular, just for people that really don't understand anatomy, that means the joint, guys. So think of the two bones, think of them surrounded by a big sock that's kind of onto the bone either side, and it's this own little world in there. So intracapsular would be inside the joint where the actual true cruciate ligament lives, and you're trying to really, really artificially replace it. Extracapsular means that you're trying to create a ligament of the same kind of angles and same influence, but on the outside.
Right. Yeah, absolutely. And again, like this, that's just a big term in terms of, like, that's not one technique. In even just under that umbrella term, there's lots and lots and lots of different ways of performing that technique. But the general application of that would be that we use an anchor on the kind of the back of the thigh bone, on the back of the femur somewhere, and we use another anchor point on the front of the shin bone, or the cranial aspect of the tibia. And you put some kind of prosthetic material between those 2 points and tighten it up to the point that the abnormal motion that we spoke about last time, this draw that we feel between the tibia and the femur, is obliterated. So it's really just exactly like that. So yeah, so it's aiming to go at approximately the same angle as the cruciate ligament. Now, there's a lot of chat about which way of anchoring that is better. Is there one way better than another? And a lot of that is personal preference, because even if you try and look into the literature in depth about it, the papers don't even agree with each other. So it's very hard to say that one way is better than another. But normally, very, very commonly, there's a little bone on the back of the femur which can be used very easily as an anchor point. And then we drill a hole through the shin bone as the other anchor point.
And then there's also different materials, aren't there? Because I've you know, there's been the nylon-y fiber, and now there's the fiber and wires. And
right,
all manner.
Absolutely. Yeah, and I think obviously then there's kind of the less invasive techniques, and then maybe the comparatively slightly more invasive techniques. Some of these techniques can be placed relatively closed, others are placed with a standard open approach. Now, in terms of, have we proven that one is better than another? I said there's loads of materials out there, there's loads of anchor points out there, all those kind of things. Should you be going to one person over another because one is better? No, we haven't proven that one is better than another. The only evidence that I'm aware of, and does it really stand up as evidence, is that they certainly did do the Veterinary Orthopedic Society did a very large kind of questionnaire, if you like, of all of their members and people that attend their conferences, and asked them what complications they'd encountered with which techniques for cruciate disease. And what they reported, really the only significant finding they reported out of that, was that the tightrope technique seemed to be associated with more complications. People had more difficulty with that, had encountered more complications with that than with other techniques.
And is that, do you mean lateral suture in general, or do you mean that that's the material?
That's the specific type of lateral suture there. So that's one that's a braided suture. So rather than just that single strand nylon, it's a braided structure, and that is definitely stronger, which I think is why people were initially very keen to try and use that. Maybe they'd have fewer breakages of that material, but braided material is also very good at harboring infection. And infection rates were really the thing that people had encountered, and unfortunately then removing that is very, very hard. So I've never put one of those in. I have had to take them out, and I really hope I don't have to take many more out, because it does become quite an aggressive surgery to remove them.
And does it wick in? I guess all the tissue wicks into it, so you can't remove it easily.
Yeah, well, they're placed through tunnels in the bone, and the material's so strong that you end up with great big bone tunnel. You start off with a small bone tunnel, and the bone tunnel, by the time you get in there, can be pretty huge, to the point that you have to graft it and all those kind of things. And this material just kind of frays, and you end up taking bits of it out here, there, and everywhere, rather than it coming out in one nice piece. So, but I've only seen the very worst ones. So I've only seen ones with complications, because we don't put that material in here. So I'm certainly not a balanced opinion on that, because I've only seen the ones that are infected. I'm sure there are others out there doing great, but that's my experience of that material, is that I personally wouldn't choose it. But
no. And then there's all different kind of knots and crimps and all different techniques to actually tighten. So if you imagine, guys, that this is a continuous loop. Oh my God, hand-to-eye coordination backwards. But you, at some point, you've actually got to bring the ends together in some way, and there's crimps and knots and all manner of things. So it's a very wide number of techniques for one technique.
Exactly. Yeah. So, I mean, there's so much to go into, and I certainly don't go into all of this with owners. I just kind of say to them, this is the technique, but I kind of present it to them as if it's one technique. So the aim of that procedure, once you have your prosthetic material going round the joint, is that's going to stop that abnormal motion. Now, I think the most important thing to remember with this is that this is not a ligament. This is a static piece of material. It can't stretch and relax like a ligament can. So it holds the joint completely still. And over time, as the animal uses the leg, that will stretch, it will relax. And we absolutely anticipate that these things will stretch, relax, or break, probably within 12 weeks after surgery. So it's not a permanent thing that's staying in there holding the joint stable. What it does, it holds the joint stable enough for a long enough period of time that the dog can lay down scar tissue around the joint. And it's the scar tissue in the long term that keeps the joint stable once that nylon or fiber wire, whatever you've used, has kind of stretched, relaxed, and stopped doing its job.
Right.
So it is reliant on scar tissue in the long term. And not the nylon. So that's something I think is always worth pointing out to people, because in every one of these surgeries, you're kind of walking that tightrope between, is the dog going to lay down enough scar tissue before the nylon breaks? And that becomes very important when you think about post-operative care, because these dogs have to be rested, and they have to be rested very, very strictly. And even just one slip up in your post-op protocol, there's one jump off a sofa, one running off to meet the postman, one little kind of escape, which I don't think any of us can really say would never happen on my watch. I certainly can't with my dogs. And so really just one slip up, one mistake, and one kind of outrageous person coming to the door and trying to feed your dog a biscuit, whatever. But any of those things could happen. And if the nylon breaks, you are back to square one. So that's not really
I had that recently. This guy had everything in place. He'd put the baby gates up, the floor sorted, and the dog decided to jump the baby gates. So he wished that he hadn't even put it there, because it actually made it worse. And he got his leg trapped behind the gate. And so
we all had it.
and you just couldn't predict that. The guy had done everything that he could correctly, and some things seem really out of your control. So just staying with that, going into the post-operative, because I do feel that this is something globally that we should put more attention into, is the post-op rehab. Suggest that this is something that you delay any kind of thing, any interventions, bar just lateral stabilizations, very gentle passive range of motions, etc., until a lot later than, say, another intervention. Because I know some people with the TPLOs, which we'll come to, they get into a rehab plan quite promptly, whereas with the lateral sutures, there should be a greater delay to protect and respect that. Is that how you feel?
Right. I mean, I think it's very difficult, right? Because I guess for me, the extracapsular techniques, those lateral sutures, they're going around the joint, and they do restrict joint motion more than the techniques, those more mechanical techniques. So for me, I guess I'm actually more inclined to be a little bit the other way. I think the extracapsular sutures need a little bit more rehab than the TPLOs do. The TPLOs tend to use their leg within 24, 48 hours. A lot of them do their own rehab. I'm not saying they wouldn't benefit from additional, but a lot of them will do great regardless of when they get into rehab or not. Now, little dogs with an extracapsular, sometimes they don't want to put the leg down at all. It feels tight, it feels horrible, and they need encouragement to put it down. And while I want them to protect that repair, I don't want them hopping on it for 6 weeks. That wasn't the aim of the surgery. So I'm actually more inclined to potentially be the other way, but I have to have a very good relationship with that rehab facility. If I don't 100% trust them or don't know them, then I'm a little bit more dubious, as you say, because if I'm not absolutely sure they're going to be looked after very, very well, then I will be a bit more conservative, and I'll just give the owners things to do at home, like weight shifting exercises to encourage them, even just really simple things like put their food bowl on a step so that they have to put weight on their back legs to be able to eat, and passive range of motion, icing, all those kind of things that they can do at home. So I think you do have to be super careful with it, but I do think that the extracapsulars, if anything, deserve and need that rehab a little bit more.
And that gives us a perfect opportunity to make a quite statement that when you're prepping for your cruciate repair and you're budgeting and you're planning and you're sorting out your home, have something in place for this rehab period. I think so many people focus solely on the surgery, and it might be financially, they push out their insurance budget, it's gone, they've added to get the surgery done and there's nothing left. Think about rehab. I think it's really quite important. You see some dogs that really could have done brilliantly, but they are held back because they come straight into an owner's care who just walks them and doesn't actually focus attention trying to retrain and strengthen tissue.
Right. And I think some of that's on us too, because I mean, I've certainly had cases where, my initial instinct when the dog comes back 6 weeks after surgery and the owner said, yeah, they're doing great. And but he's not weight bearing. Oh yeah, he's always been like that for the whole 6 weeks. I thought he was meant to be. And it's kind of like, wow, okay. And that's on me, because I didn't tell you what to expect. I didn't tell you that if the dog's not putting weight on the leg within 3 or 4 days, I want you to come back. There's something wrong if that's not happening. And so sometimes that communication breakdown is from us, because we just presume that someone knows what a normal.
It might not have been you. The truth is that people only actually remember about 20 to 30% of what we say.
If you're
laughing, Karen, there's no way in the world that you would have said that.
So yeah, I think writing things down potentially, and I'd say that for a long time I've kind of had these kind of pie in the sky ideas about kind of online having kind of, this is what a dog should look like at 1 week, this is what a dog should like at 2 weeks, this is what they should look like at 3 weeks, and people can just log on and say, okay, yeah, I think I'm good, like my dog looks pretty much like that. So I think that would potentially help people, but yeah, I just haven't put it together yet. I'm sure someone else will get time to do it.
So anybody that's watching this, if you would like to seriously video footage your dog through its rehab, we want it. We will create it. We will put a little timeline of this is what your dog should look like. Well done, Karen, like it. Right. We've got a quick question here about them. Laura Eldridge. Hey Laura, you're amazing. If the nylon breaks too early, and what percentage do you feel break too early?
So the first part of that question is a lot easier to address than the second one. So can it be redone? Yes, absolutely, they can be redone. And probably it's done a lot more frequently than I actually encounter, because I guess for us, if a case fails the surgery, it depends a little bit on the conversation with the owner. If we fail the surgery because there's quite clearly been an event, the dog jumped off a sofa, jumped over a baby gate, something like that, and we can pinpoint this is why this technique didn't work, then absolutely just repeating it and trying to be a bit stricter with the post-op care, maybe being a little bit more, a little bit more sedative for the dog potentially to try and get them through that period, but changing something to make sure it doesn't happen again. Absolutely, yes, it can be done again. Any second surgery potentially has slightly increased risks of infection, those kind of things. But yes, can be redone and can be expected to have largely very good results second time round, as long as the same thing doesn't happen again. If I can't pinpoint why it failed, if there is no big event, there's no trauma, there's nothing else, and it's failed a little bit longer out, kind of more like that 8 to 10 weeks post-surgery, then I start becoming a little bit more concerned, because I can't figure out why it failed the first time round, and I can't see what I can do differently to make it go better the second time round. So if I can't see what I would do differently, then I'm more likely to say, well, I think we should maybe go with a different technique this time round, because it's kind of just don't do the same thing and expect different results. I guess would be my feeling on that. What percentage break too early? I think that's incredibly difficult, because it's so dependent on post-op care and all those kind of things. I think if the technique is done really well, and certainly there are some older surgeons I work with, a surgeon, Dr. Flo, who actually basically was the creator of one of these particular types of techniques. And so you can't really expect anyone to do it any better than her. She came up with the technique. She's been doing it all her life. She's now in her mid-70s and still doing it. If you've got someone like her doing the procedure, and she has a fabulous success rate with it, and then certainly I think she probably has a very, very low failure rate. If you look at a younger surgeon who primarily does TPLOs or TTAs or whatever their choice is, and every so often they throw in a lateral suture because of cost restrictions, or just because that's what the owner wants, or for whatever reason, then probably their success rates are substantially lower. So I think it's very surgeon dependent, and I think if you do it right, the success rate should be close to 100% if you've got the right surgeon and the right recovery. But certainly not everyone gets those results.
Okay, Jill, we're going to come to yours about, so why not just do a TPLO if rehab is better? We'll come to it after we've discussed TPLO. Just to finish, you still have to go into the joint. I think some people think that they can use an extracapsular because you're not going to go into the joint. You still do. Do you want to explain why?
Yeah, absolutely, and I think that's a very, very valid point. And again, it's a source of major controversy within our field, to be honest. My perspective is that actually, I'm just going to come out and say it. In my opinion, it's unethical to not go into the joint. So that's one point where I do think it's I have a pretty hard and fast line on what we do. But every surgery for a cruciate, from my perspective, it starts with either doing an arthroscopy, looking into the joint with arthroscopy, so minimally invasive, or opening up the joint and having a good look. And the reason for that is one, the damaged parts of the cruciate ligament currently are just flapping around in the breeze, causing more inflammation. So you want to get rid of those. But the most important point is that from the outside, we cannot tell, even if we did an MRI scan of this dog's knee, we could still miss it, whether they have a meniscal injury or not. And those menisci are kind of almost like little kind of shock absorbers within the knee, and they make up the difference between our curved surface of the femur and then our flat surface of the tibia sitting underneath. They have a lot of different functions. They stabilize, they help dogs know where their foot is in space, and all those kind of things. And when we have this abnormal motion of the knee, the meniscus on the inside most commonly can get flipped forward or crushed, and they are full of nerve endings. So they are super, super painful when that happens. And if we go ahead and do a surgery, it doesn't matter how well I stabilize the knee. If I leave a meniscus in there that's torn, this dog will do terribly. We need to go in and remove those. And I don't believe that we can ever say definitively from the outside the dog has one or not. So we really do need to look, and we do need to remove any ones that are damaged. And studies have reported up to kind of 56% of cases that have a meniscal injury. So it's not rare at all.
Yes. Yeah. And do you find that you have better results going in arthroscopically? Compared to actually opening up?
I think for me, I think that the arthroscopy is very nice in terms of, it's obviously you get the magnification, you get the illumination, you can see a little bit better. So you might pick up things with arthroscopy that you might not pick up with an arthrotomy potentially. A lot of that's going to be based on that surgeon level's experience, how many they've done, those kind of things. However, I find it a little hard kind of saying, well, I'm doing a minimally invasive arthroscopy and now I'm going to go and cut your dog's bone in half. So I'm just a bit kind of, it's not a minimally invasive surgery. So I have to be honest, for me, if I'm going in for the first time and I'm going to stabilize the knee, I tend to look open. If I have a dog that I want to look into the knee and I've already stabilized it, if I think there's a post-op complication, a late meniscal injury, something that's happened later, then I think arthroscopy comes into its own there, because potentially you can just do a very, very minimally invasive surgery and remove a meniscus. But if I'm doing the stabilization as well, I tend to just go with open because for me it's quicker.
Okay, that's good. Good clarification. And I was quite surprised recently. I didn't realise that the cruciate ligament is not just the inflammatory source, but it can also become a bit of a mechanical impediment if you've got the cruciate there just like scarring away. Is that another reason that you think I must get rid of that debris, I must clear that out? Have you?
Yeah, I think there's a huge amount of debate about this, to be honest. Like everyone, like most people agree on the meniscal issue. Not everyone, but most people agree that we need to go in, check the meniscus. Now, in terms of whether people take the cruciate out, I think if it's completely degenerate and you've got strands, then most people do want to remove those. And I think that is mostly the kind of ongoing inflammation, potentially ongoing pain side of things. There've been a few cases, and I don't think anyone's ever written them up, but if you speak to people, most people have seen 1 or 2 cases that have come back following a surgery, not doing well. You've re-explored the joint and you've found the piece of cruciate ligament that you'd left in. You don't find anything else to do. You just remove that piece of cruciate ligament and the dog goes on and does better. Now, it's not very scientific. Yeah. Anyone who's experienced that, who's had to go in and do that, tends to be very careful then, I think, about always removing any damaged parts. Yeah. I think the debate really comes in if you've got a piece of the cruciate ligament. If we said, I think last week, that it has 2 bands and that one can rupture and the other one maybe can be intact. Yeah. If you have one part of the cruciate that looks intact, that looks great, that, you know, that looks perfectly healthy, sometimes that's a little hard to justify. You don't really want to take it out because, as we mentioned, it has other functions. It prevents internal rotation, it prevents hyperextension of the knee, all those other things as well. So if you've got a band that looks completely healthy, that's where you'll find about a 50-50 split of surgeons in terms. Some people say, I'm taking it out in case it becomes degenerate and causes pain later. And some people will leave it in saying, well, if I do a good job with my repair and I stabilize that knee, maybe this remains intact and helps against those other functions. Wow. So I think there is a lot of debate, and to my knowledge, we don't have evidence to suggest who's right in that argument. And I have definitely come down on both sides of it. I'm normally the person that takes everything out, but if I see a cruciate that looks largely intact, then I have left those in, but I can't say that I know that one does better than another.
Okay, that's good. That's good to know, because these are the sort of questions that only you're fired with quite a lot of info, and it can be really difficult to take it all in, you know. Before we leave it alone, what about using any of the biologicals? Do you, with your lateral sutures, do you put a PRP or anything like that in as you leave? You're just mechanical stabilization?
I don't. I mean, I think we know that the synovial fluid after a surgery reforms and is back to kind of its normal volume within kind of 24, 48 hours probably. So it's, to me, I'm going to like, there's going to be even if I close that joint capsule super well, I'm not sure it stays where I put it.
No.
So yeah, so for me, I don't, because it would be additional money and I don't have the evidence to back it up.
That's why I mentioned it. I think
that's something I don't do, but there's also nothing to show that it makes the dogs worse. So for anyone who is doing it, it doesn't mean I think they're wrong. It's just, I say, I don't have the evidence, so I don't do it.
And I think I've said that in case they've just had an estimate for a cruciate and it's part of the estimate and they're saying, oh my God, that's just pushed me too far. Actually, that money could have been better spent in the rehab thereafter, because it might even be £500 towards.
Right. Yeah, it can be. Yeah, it can be expensive, and I think the jury's really out on PRP and whether it, you know, what it does and whether it does and all those kind of things. And certainly, if it's additional cost, then and it's a cost and cost is an issue, then I would definitely be the person that would say then take it off the table.
Yeah. Okay. Fair. Good. Whew. Do we feel that we've done extracapsular? Are you happy?
I think so. I mean, unless people have other questions on it, which we can always
completely gone or not. Okay, so that's about patella. Right, let's move on to TPLO and then we'll come back. Okay, so I think it was in my lifetime, which years as a vet.
Only just
that the whole new way of thinking came to me. Explain that.
Yeah, so I think it's one of those things that obviously this Barclay Slocum is the person we have to thank for the TPLO. He's the person that came up with all of this and really started this whole way of thinking, and everyone else has really copycatted on since then, really. Yeah. So the aim was, well, we weren't having great results with what we were currently doing. You know, the lateral suture works well some of the time, but certainly larger breed dogs, sometimes you're putting in 4, 5, 6 strands of nylon. Sometimes they're still failing them. You know, we weren't super happy with everything that was going on. We thought there must be a better way. And it was him that really came up with the whole idea of, well, you know, the main function, although he said Cruciate does have other functions, the main function that it has is preventing this kind of cranial slipping forward of the shin bone relative to the thigh bone, or the tibia relative to the femur. And so, you know, if that's what we really want to stop, then the reason why this happens is because the tibia in dogs has a big slope on the back of it. So everything, and you've got a curved bone sitting on top. So obviously it wants to slide downhill. It's natural. It's just biomechanics. However, if this is flat, then it doesn't want to slide downhill, and then you don't need to have that cruciate ligament in place potentially. So that was what was put forward. Initially,
do you think when he first said that, everybody went, "Oh my God"?
Oh, I'm sure they did. Yeah. And you can look at it, but it's a ligament problem. You're going to cut my dog's bone to solve a ligament problem.
By the way, I want to make the hole a lot bigger.
Right. Yeah. I'm going to controlled fracture your dog's bone because it has a ligament issue. Like literally, everyone's like,
I would love to have been there.
Like fly on the wall for Barclays Locum. Absolutely. Can you imagine? So this was like 1980, like early 1980s. I think this was all kicking off, and initially they were taking to kind of level that slope. Initially they were taking a wedge of bone out. It was actually a triangle they were taking out initially, and then just flapping that bone down. So you can imagine that was also making the bone a little shorter. It was changing the axes of how the bones work. So there was some concern that might be worse for arthritic change post-op, because we were changing loading of the joints, and we know that that's important for osteoarthritis progression.
Yeah.
And so the next stage was, well, hang on a second, why don't we just make a semicircular cut in the top of the bone and rotate that around? And so that's become the go for it. That's become the kind of the thing that we do. And the way that they looked at this was saying, well, you know, maybe we don't need to take it all the way up to being completely flat, because we need to think about the other ligaments in the joint, and we don't want to put any of those under increased strain. And so there was a huge amount of research done, and the decision was made that if we, oh really, I'm gonna like get red marker and make all the mistakes. but yeah, so kind of they did a lot of research and worked out that most dogs are standing at about, most Labradors at least, standing at an angle around 27 degrees with that slope on the back. And if we take them up to being at more like 5.5 to 6.5 degrees, that we stabilize that knee, they don't need a cruciate ligament, and they and none of the other ligaments come under increased stress or degenerate in response. So that was kind of what was put forward, and then that is stabilized with a plate and screws. So I guess when I'm talking to owners, one of the things I kind of put forward to them is, well, you know, you've got a crazy like Labrador that's absolutely nuts. He's maybe only 3 or 4 years old, and he's used to going on 6-mile runs a day. And do you think he's more likely to fail a strand of nylon, or do you think he's more likely to fail a massive plate and screws? And so this does come into the post-op care a little bit, because for me, with an extracapsular, they are strict rest. It's 5-minute walks maximum. They're not off a leash the entire time, and that's a kind of 6 to 8 week recovery. Whereas with the TPLO, I'm kind of like, well, 2 weeks of 5-minute walks, 2 weeks of 10-minute walks, 2 weeks of 15-minute walks, 2 weeks of 20-minute walks. And if they want to be outside of the crate, as long as they're not jumping on and off furniture, I really don't mind, because I trust that implant and I trust that it's going to hold up unless the dog does something really quite ridiculous. And yes, that depends on having done the surgery appropriately. But if the surgery is done well and an appropriate implant is used to stabilize that, then really those dogs should be able to very comfortably weight bear from 48 hours post-surgery.
And that's what happens, aren't they? You have them come in and they're toe touching and they walk out and they're actually placing weight through. It's quite amazing.
Yeah, they do. I'm disappointed if my dogs are going home the day after surgery and they're not at least putting the toe to the floor. So that's what we generally expect from them. Yeah, so that was the kind of the technique that came out first, and then from there on, there have been a huge number that have come on that essentially work on very similar principles, slightly different mechanics, but essentially working very similarly. So the TTA was, I think, the next one that came out. So it's tibial tuberosity advancement.
That's
achieving the same thing.
It's kind of completely different looking, isn't it?
Oh yeah. Yeah, absolutely. It looks completely different.
I'm not going to even try.
So that takes instead of taking a semicircular cut at the top of the tibia, that takes a cut down the front of the bone, and then moves it forward, with the aim being that it kind of, if you've got the back of the tibia sitting like this, and you have your patellar ligament running down the front, it aims to make a 90-degree angle there. So it's all about angles, as you can imagine, with cruciate disease. That's what we're talking about. But TTA essentially. There you go. So TTA then was the next one that came out. That got hugely popular in Europe. It was probably the most popular cruciate technique in Europe, other than the lateral suture. It almost overtook TPLO.
It just exploded.
It really did.
Exploded.
Yeah.
And that actually, yeah, there was a lot of courses, weekend courses, left, right, and centre. And then there was a slight decrease in popularity.
Yeah, I think TTA is one of these things. I think TPLO, there's one complication that a lot of surgeons get very, very worried about, and there's a big artery that runs down the back of the leg that your saw blade comes very, very close to, and it's the popliteal artery. And if that does get involved in the cut, it's scary, yes, but as a surgeon, you just stop it. So just find the vessel, clamp it, stop it. It's scary, but it's very, very controllable if you have the experience and you know what you're doing. If you panic, then that can become potentially a life-threatening complication. So I think a lot of people were super, super nervous about that. The approach for the TPLO seemed big, it seemed aggressive. And if people were used to doing patellar luxation surgery, which a lot of people were, the TTA cut is essentially very similar. So I think people felt a little bit more comfortable with it, and maybe that's why it became so popular. It was super well marketed as well, and the courses were run very well. So, but yeah, there was a bit of a split, US and Europe wise, in terms of popularity for those techniques. As time went on, there was initially, when TTA first came out, there was when the papers started to come out, people were saying, well, there seems to be a higher incidence of meniscal injuries after surgery with a TTA than there is with a TPLO. Now, I think more recent studies have not really confirmed that, but that's something that's persisted in in everyone's knowledge. Everyone's going, oh, it has a higher risk of complications. My opinion is, I think the TTA is not easier. I do both. I don't think the TTA is easier. It was marketed as being easier. I think there's more steps to it. It's less forgiving of a minor error. I think if you get it perfect, then these dogs do great. But if you get it even remotely not perfect, that it's not very forgiving of any poor technique. So, or just a mistake, not even poor technique, just making a mistake, or a dog not being a great anatomical candidate. So it works beautifully when it works beautifully. I have done it a lot. I think there are cases where it is a great technique. But there's lots and lots of steps. There's lots of room to make a mistake if it's not something you're very, very confident with.
Okay. With both of them, you still have to go into the joint.
Yes.
Still have to do the whole thing, just so everybody's clear with this, because
that's the most important part. The most important part of the surgery: go into the joint, clean up the joint, get out the meniscus. In fact, there was a study, I think it was Bristol University, tried to do it several years ago. Tried to do a study comparing going in and just exploring the joint and then not stabilizing it, and going in and exploring the joint and then stabilizing it. Now, not surprisingly, not many people signed up to be in that study because they didn't like the idea that their dog's knee wasn't being stabilized. So they didn't get very many cases. But interestingly, from what I remember, I think the cases that they did get, it showed that even the dogs that just went in and had an explore and the meniscus removed still did pretty well. So I think that's a very, very major part of the surgery. If you're going to miss a part, it shouldn't be that part.
And do you think that was all to do with No. Do you think that was all to do with the meniscus, or do you think cutting into the joint capsule and meddling with are we going to encourage scar tissue to form?
Yeah, you're going to stimulate scar tissue, and obviously all of these dogs were then rested for 6 to 8 weeks, so they were all kind of getting medical management and conservative management of the injury as well. So obviously there's a lot of things that played in. And I think they only had it was like 8 dogs or something. It wasn't many, so that you can't really make any conclusions based on it. But people have tried to kind of look at that and pull these things apart. What is it that makes the difference? But definitely don't skip the arthrotomy part. Don't skip looking in the joint. It will only come back to bite you in the ass.
And I think this gives us a really good opportunity to just very quickly remind people about studies. I'm I'm quite happy for people to know how stupid and gullible and naive and not worldly I am. And when I started, Karen, was I reading the papers about a huge number of dogs that will have cruciate cuts for surgical techniques to be tried. Getting owners to come in on a study where you're giving them the suboptimal option is nigh on impossible, isn't it? So, then you've got to go into the lab kind of trial facility, and then you've got dogs that have to go through this that didn't necessarily have it.
Right.
It's very complicated, isn't it? People really get upset when you say, yeah, 12 beagles that had their cruciates cut so we can investigate whether this technique worked or not.
Right.
It's very hard. So getting trial data is not easy. So if anybody goes, oh, they should know by now, actually, it's really complex.
Right. It is. And I think it's becoming more and more, and rightly so, becoming more and more difficult to have those kind of trial populations of dogs. And I think that's absolutely correct. But the problem is that all the studies we do on clinical patients, there's so much variability between them that it becomes very hard then to pull out what the results of that study are and how reliable they are. So I agree with you. Research is a very, very tricky thing to do well. Yeah. And a lot of research out there that's maybe not done super well, and it doesn't necessarily mean that the person who's doing the research was bad. It's the limitations and all the things that people face when they're trying to do research.
Yeah. And there's also just the natural aspect. If somebody does choose conservative and they don't want to go for surgery, they do veer away from the vet practice. So yeah, we don't continue to collect the data of how well it's doing. And brings nicely onto something that I'll really, really briefly mention. We've got a current situation where people are being delayed from having surgeries. Is that going to have any impact on whether they do finally go for surgery? So if a dog is for a surgery and it's now not going to have it for 6 to 8 weeks, what is going to be the repercussions of that? Yeah. Are they going to deteriorate, or are they going to naturally stabilize and people will choose not to go for the surgery? Who knows? I know people that are interested in that, but that's another time. Going back to these different interventions, we've really done well on the podcast. We've got these dogs that are walking out quite quickly. We've got a predictable rehab. We've got interventional rehab quite quickly. You've given people a really kind of positive timeline. What do you see happen if it's not going so well? What kind of things can you see?
Yeah, I mean, I guess obviously there are certain complications that will be very much across the board, and others that happen specific to each technique. So in terms of obviously infection, that can happen with any of them. As far as the rate is pretty consistent amongst all the procedures, it's not different. The one thing I would say with infection, and because that is probably the most common complication that we talk about, is that if you have an infection with an extracapsular suture, then your revision option is going to have to be go and remove that suture, because the implant is going to be infected most likely, and the infection is going to keep coming back unless the implant is removed. So removing that implant is a fairly simple and easy thing to do. You just need to be careful that you don't disrupt all that scar tissue that's formed and that is now stabilizing the joint when you go in to remove it. So you need to kind of be careful about how much dissection you do, how much you disrupt that. But removal of that is really pretty easy. Similarly, if you have to remove your TPLO plate because that becomes infected, that's super, super easy. You just wait until the bone is healed and then go in, remove the plate. Right. 10, 15 minutes max. Now, TTA, very, very different. Removing TTA implants is far, far more complex. And I think that's one reason why people have started to kind of drift back to TPLO a little bit. Is that if you've had to remove a TTA implant, the bone grows into it. The bone grows into the cage. So in order to take it out, you have to make a great big hole in the bone to remove the cage. The plate's easy. The plate comes out very easily, but the cage itself can be a little difficult. So I think that is one reason why people have started to drift back. Once you've removed a couple of TTA implants, you probably don't want to remove many more.
And let's remember what's attaching to the tibial tuberosity, not something small. We're talking the whole quadricep complex is going straight down there. Just
right. Exactly.
Yeah, we need some strength there.
Yeah. And also the TTA implants, you can't remove them until they've filled in that great big gap that you created with advancing the tibial tuberosity. Yeah. So you might end up having to wait quite longer to be able to safely remove those implants. than with a TPLO, which normally at kind of 8-9 weeks after surgery, you can quite comfortably go and remove those.
Amazing.
So,
okay.
Yeah, that is difficult. And just in case anyone's wondering, obviously TTA, TPLO, certainly not the only ones. There's a triple tibial osteotomy. There's a Cora-based leveling wedge osteotomy. There's so many others as well, but they do all function on very similar principles. So that's why we haven't really gone into all of them.
No, and that's the thing is because it does get confusing, and because I'm not an orthopedic surgeon, I never ever dream of having the guts to do it. Whew, you need a really calm demeanour in there. It does get quite complicated because there's all manner of different anagrams coming out, and I can't keep up with it. Where does where are these all coming from? Are they? How do you get an implant, a new technique? How does it come to fruition? Where does it come from? Blah 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 blah.
Yeah, I mean, I think normally it'll be something that someone has just obviously most people who are orthopedic surgeons have done a lot of TPLOs. So for whatever reason, they think that there's something they could do differently. So and a lot of it comes down to altered weight bearing, and obviously that despite no matter what we do with cruciate disease, as we mentioned earlier, it doesn't matter what surgical technique I do, arthritis is going to progress. And I think a lot of these techniques are saying, well, maybe if we can kind of have the limb more like a normal limb and the loading through the joint being more normal, then maybe we can slow down the rate at which that arthritis does progress. But to my knowledge at this point, no one's proven that one technique is substantially better than another for that. Arthritis will progress in all of them, regardless really of what we do. So I guess there's the other side of that, which I hope doesn't play too much of a role, but also, as you mentioned, cruciate disease is a fairly lucrative business out of the veterinary field. It's probably the most lucrative business, and so maybe some people jump on the bandwagon to try and make their fortune. I don't know, but yeah, I'd like to think that it's more that people have genuinely think that maybe they can improve some aspect of what we're doing. I
do think that owners really need to, owners be in charge of this. Ask questions. Ask what the technique is. Come back to us if you're a bit worried. And enough people contact Cam and say, look, we really need more information about this. We will create you a folder, a resource of reliable information that you can download of all the different techniques. I'm more than happy to do that if you want it. Just everything takes time to do. But please be in charge and question what it is you're going to do to my dog. Tell me all the strengths and weaknesses. We've got someone here, Amy Sharp, my vet and boss, anti-TTA, and said TPLO was too invasive for my dog, and said MMP had a better recovery. It hasn't for my dog. What's that?
Right. So MMP is kind of, it's almost like we have TTA and then we have TTA2 and then we have all the other things. It essentially mechanically is doing what a TTA does. It's advancing the tibial tuberosity, but by placing a wedge down between the two bones rather than... Is
that the staple? Then it has like that glorified staple one?
No, it's a great big wedge of kind of like porous looking material that the bone apparently grows into. So it's not a technique that I've ever performed. To my knowledge, there's absolutely zero evidence to back up that it's better than anything. In fact, I don't even think there's a case series of MMP that's with a large number of dogs that's actually been published out there. So no evidence to my knowledge that it's better in any way, shape or form. I would compare it to TTA results because that's the one that's most common, that has most in common with in terms of the mechanics that it's actually simulating. But say it's not something I've done, again, mostly because whenever I thought to myself about how on earth would I get that implant out if it got infected, I couldn't work out how I would do it and how I'd be able to stabilize the joint.
I love the positivity.
I was like, no. Something that scared me. So I'm just like, no, anything that I can't work out how I would take it out if I needed to, I'm very, very wary of. So
I think, do you know what though? I think a lot of people would happily travel to you a long blimming way because you put, as you say, so much thought into, or you're very military, you're like, what's going to happen then? What could happen? How am I going to deal with that? But I do think you're right. You need to consider all eventualities.
It comes from that's partly just being someone who takes every failure very, very personally. As few as possible. If I plan everything to the nth degree, at least if it goes wrong, I can't say it was for want of trying.
I'd hate to see what you like cooking. It must be scary. You must.
I don't cook, I bake and I ice cakes, and it's military. Is
it military?
Yeah.
We've got a question here, and then we've got about 8 minutes to talk about post-operative care for all of them, like So Rachel Meadows' question, please. I have an older dog, 12, who had surgery last July. He weight bears if he forgets not to. He hasn't coped with surgery well, and touch is an issue for physio. How ethical is it to leave it well enough alone? He's on, let me put it across so you can read it as well.
Yeah, I can read it. I've got it on the side actually. So yeah.
Okay. He's on great pain med now. It definitely didn't work. Should I leave it? So he weight bears.
Sounds like you had a surgery that didn't work. Yeah, yeah, and I think this is one of those things. Actually, just looking into the literature when we talk about animals that have had surgery, obviously I see a lot of animals that are prepared to come back for a second surgery, sometimes even a third surgery, depending on what's been going on. Obviously, hopefully, I didn't do the first one, but yeah, it's actually the vast majority of owners, if they've been through one surgery, do not conscience for whatever reason going through a second one. We talk about revision surgery a lot, but the vast majority of owners don't go through with it, and that can be financial. It can be again, because they think that their dog for whatever reason just didn't cope with it. Those kind of things. And I think in terms of ethically leave well alone, you know your dog best. And if you think your dog is having a good quality of life currently as it is, and just limps occasionally, then absolutely it's ethical to leave it as it is. I guess the things to be aware of, if it was cruciate disease as opposed to a traumatic rupture, I would be a little concerned what happens if the other side goes. I think he'd suddenly probably be quite debilitated if he's limping quite a lot on that leg and then the other leg acutely ruptured. So I think in this situation, what I normally advise owners is there's no need to rush into anything, no need to go there. Just be prepared that if the other side were to go, you might get pushed into making a decision fairly quickly because you might end up with a dog that's really struggling to get around. So just be prepared for that eventuality. And I guess whatever the surgery it was that you had on the other side, maybe think about pursuing something different on this side if we don't have a specific reason why the dog didn't do super well initially.
Yeah. And being interested in rehab, have you explored rehab and conditioning and training to see an improvement on what you've already got, so actually having therapeutic exercises to start getting some muscle memory back, some trust, some confidence in weight bearing. There is a lot up here that goes on as well. I believe it that dogs will choose the path of least resistance. They wouldn't, if they're so used to carrying it, they'll just carry on carrying it. But if I've actually seen it, they do. And you do have to train them to have confidence that that leg's got stability and it's not going to hurt when they place weight for it. A bit like that. There's another question down here. My boy had the band with his first surgery about a year ago. He's had a similar to a TPLO on his right, left around 6 weeks. When I looked at his x-rays for both legs, it's clear the band had failed. What do you guys feel about? What does she mean by a band? Is that the lateral?
I'm guessing that's the lateral suture. Yeah, I'd imagine that's a lot of people call it the band here as well. So I think obviously, how do I feel about it? I'm going to be completely honest. I mean, if cost was not an issue for someone, if all other things being equal, I would perform a TPLO every time. And I think there was a comment about this earlier, and it's just because for me, I find that the recovery is much more predictable. They weight bear much sooner. They're far less likely to require any intense rehab for me. And the complications that we do encounter, because every technique can have complications, but they're few and far between, and they're easily dealt with when we do encounter them. So that for me is the reason to choose a surgical procedure. And I guess for me, maybe it's a little easier again, because when they come to see me, I'm talking about, it's about $1,000 difference for us between the two techniques, but neither one is cheap in my hands. So if they're coming to us, generally by the time they've spent that money, a lot of them are prepared to spend.
I'm just going to clarify, Karen doesn't actually earn this. When you say in my hands, you're in the university.
No, in my decision-making hands, like it's those are our priorities.
I would hate anybody to be thinking that there was cash at the door.
No, absolutely not. I am the same no matter how many surgeries a day I do and what they are. So
yes, that's pretty normal for most vets.
but yeah, I think that's my preference. But when you look at the other situations people are in, it might be a situation where their local vet can do the extracapsular or the lateral suture for £500, and then it's going to cost them £4,000 to go and have the TPLO done in a specialist facility. So while the difference isn't very big with me, the difference is huge if you think, if they're having surgeries done elsewhere that can be performed by someone who's maybe in a facility with less overheads and all those kind of things. So I think, obviously, I say all things being equal, I would do a TPLO every time, but it's a bit of a flippant statement. But yeah, I agree with, there was a comment made earlier, like, if you're saying all of this, why not just do a TPLO every time? And I was like, because of finances, it's normally finances that will stop us doing the TPLO.
Okay. Last one, and then we're going to just do a very, very 2 to 3 minute overview of generic post, no matter what surgery you do, and just some flags for people. Rochelle, I can't see his surname. My dog had a TPLO on one leg, 9 repair on the other. His leg with the TPLO is much more bow-legged than the other, and now 6 years after surgery, he's starting to not raise it up as much as his other one. I'm thinking he's feeling pain. Could the plate be bothering him?
Yeah, I mean, that's possible. And so this ties into, there was a comment earlier about someone had mentioned that they'd been advised to have their TPLO plate removed, and yet it wasn't causing the dog any issues, so they left it. And I think that's perfectly reasonable. I would never advise removing implants that are not causing a problem. However, the TPLO plates can cause a problem, but normally what we see with that is that the dog's irritated at the area directly over the plate. So they lick at that area, they irritate that area constantly, and they often come up with little wounds over that area, either because they've made them or because there's a low-grade infection which is causing something to come out from the inside. So wouldn't normally see a dog be bow-legged associated with an implant associated kind of just irritation. Bow-legged, most likely for me, there's 2 things that I would be wanting to, I guess, assess for on an orthopedic exam there. One would be, is there a click in the joint, or is there pain on manipulation of the joint itself? Because dogs, if they have a meniscus which is bothering them, will try and shift their weight bearing so that they can get weight off of that meniscus almost, or take pain away from the affected area of the joint. So that would be one thing. The other thing would be that sometimes with TPLO, if any alignment was altered when the TPLO was performed, the kneecap can start to slip secondary to that procedure. So you might have a dislocating patella, and that's the most common reason that I would see a dog looking bow-legged. So I'd want to know if the kneecap's stable, and I'd want to know if there was any pain on the joint, because I would be looking at those 2 as being more likely complications for what you're describing than a plate-associated irritation. But obviously, I could be wrong, but that would I would look for.
And then that actually answers somebody else's question that was saying that they were really seeing their dog throwing their weight into their forequarters, offloading the TPLO side, and it looked like the leg was at a different angle. There are so many questions. I think if you would be ever willing, maybe once a quarter, we could just go back over Cruciates, and just get current, and we can just start building a file of these videos that are just friendly, fun, trying to help you guys, because it's a massive decision.
Oh, it is. It's huge. Yeah.
It's huge. I think it's only when I had to go through elective surgery with my own dog did I actually really go, oh my God, this is a big decision to make.
It's so true.
And I think sometimes people do feel rushed. So maybe these friendly little video clips of us just keeping current, maybe going over the same ground, maybe adding a few little bits would be really useful for people. We've had a load of people talk about how they would love to have a reliable resource going through the different, and maybe that's something when you've got time, because I know you're super busy, or maybe one of your students. Yes. Yes. Maybe we could do something, because it's a really big associated area to OA. It's they're together, aren't they? So we'll see what we can do, guys, and we'll try and create a section in the new website when it comes out. What about a few just general bits of advice? Only a few more minutes to go. What would you say to anybody, no matter what surgery that they've done or chosen, post-op care?
Yeah, I think that comes back to one of the things you were saying, people sometimes feeling rushed into surgery. And I would say, one, don't ever let yourself get rushed into surgery for a cruciate, because leaving it 2 weeks, 3 weeks, 4 weeks is going to make absolutely zero difference to your dog's outcomes, as we mentioned earlier. So even if they do develop a meniscal injury in the meantime, it won't affect long-term outcomes. So don't let yourself get pushed in. The complications that you can have from not being prepared to do your post-op care are going to be far worse than any complications you would get from leaving your surgery for a couple of weeks. So be prepared to do your post-op care. Now, every dog's different. And obviously, I normally say, ideally, I want these dogs in a crate between walks, at least for the first couple of weeks after surgery. Now, some dogs can't tolerate that, but if they can, that's what I would do. And do not feel guilty asking for some pharmaceutical support to allow your dog to do that. So trazodone, whatever is needed, whatever works for your dog, high dose gabapentin, whatever helps them relax and deal with that is fine. So yeah, do prepared for crate rest, or if your dog will not crate rest, a small utility room where you can kind of make sure the floors are nice non-slip floors, put some rubber matting down, go to a carpet shop, get that offcuts. It doesn't need to look pretty, it just needs to be functional. So just put something non-slip on the floor and keep them in a nice small enclosed area. Baby gates avoid if you can, because they do jump over them. They're so keen to come and see you and get involved in life because that's what they're used to. They will manage to get over things. So doors preferably, or crates with tops on them. Not these little playpens, because again, they just jump out of them. But people are great at coming up with things. The pictures people have shown me where they've just completely remodeled their house almost for their dog's recovery. And all the sofas are upside down so they can't jump on them, and they've all shoved everything into a corner. They've made a little fort almost in the corner for their dog, and all those kind of things. I think we're always very keen about having lots of beds and cushions for our dogs. Be careful about that, because if they slip off the edge of cushions and all those kind of things, that can be a tricky for them. Not so much that I think it's going to fail their surgery, but it might make them more painful temporarily. It's just something we want to try and avoid. So level surfaces, things that they're used to, as opposed to just introducing a whole load of new stuff for them because they've just had surgery that they then have to try and get used to and they've never dealt with. Ramps only if your dog's already used to them. Otherwise, again, I find them worse rather than better.
It's a bit like a swing bridge. So many people don't think about it, but swing bridges freak lots of people out. You know, that's a dog going up a woo.
Right. It's so true. So if your dog's used to it, then great. But if not, then probably best to kind of, I don't know, try and find a neighbor who can help you lift the dog in and out for the 1 or 2 times you're going to need that to happen. So yeah, but really just rest, and resting as strictly as you can, with controlled leash walks in the meantime. And the thing that I think that's probably one of the most useful things that anyone ever told me is you need to walk them super slowly. If you're walking your dog at the appropriate rate post-operatively, it will be super uncomfortable for you. It'll feel super, super slow, but you need to walk them slowly. Otherwise it's easier for them to walk on 3 legs. The slower you walk them, the more you're encouraging them to put that leg down. And that's what we want them to do. So I don't want them protecting it. If they're protecting it for longer than 4 or 5 days, something's wrong. And we need to get the dog into rehab, or we need to see the dog back and see what the problem is. But they should all be weight bearing by 4 or 5 days.
I think that's brilliant. And I think, as you say, there's a real scope for a pictorial video kind of library of this is the date of what you should expect to be seeing. And if you're not there, then have a red flag go off, talk to your vet. You're fantastic.
Right. Yeah. And I guess the other thing just to finish off on is that there's some older surgeons that might say to you, well, I want to keep the dog a little uncomfortable so that they rest better. I'm not in favor of that. I think these dogs should be on analgesia, and I send them home on at least 2 medications, often 3 if the dog seems a little sensitive. So always a non-steroidal unless there's a systemic reason not to. Normally I'll include amantadine on that, and often gabapentin as well if the owner is going to be able to give that reliably 2 or 3 times a day. So definitely analgesia, definitely ice packing for the first 3 or 4 days, and then starting some gentle rehab from 3 or 4 days onwards, maybe switching to some warm packing and to loosen everything up, and then starting some passive range of motion as soon as the dog is comfortable enough that they will allow you to do that.
Love that. It's just a yes from me.
Even with my weird hat.
With your amazing hat on.
I've never noticed what a strange head shape I have until I sit on FaceTime with a scrub cap on.
No, I was just talking about, I just look at my nose. I have to look up because you've got a perfect this whole vanity thing. Right. What is your Twitter tag so people can follow you? Because I know that you still do bits and bobs on there. And so
it's at Karen L Perry and then a K on the end, at Karen L Perry K, and it's that's, for me, that's a work thing, so I only really post about work on there, like 99.999% of it. So if you want to see some acute fractures or some of the joint cases that we see, then certainly feel free to have a look. Really? I promise I won't bombard you with my personal life.
No, because it's just martinis and running through woodland. No, everybody says that you're absolutely fantastic. You've had amazing compliments. You know, people saying Karen makes it so easy to understand and love the evidence-based approach. So important. People saying, yes, please, can we get some research with references so that people can feel quite confident that they're as up to date as they can be for the elective surgery of their dog. You know, it makes sense. These are our companions. We want to be doing the best. So yes, I will post the Twitter link. Just say it again. So at Karen Perry.
At Karen L. Perry. Karen and then there's a K. Karen L. Perry K.
Cool. We'll put that at the bottom. Thanks, Karen. I'm going to get you guys, whoever's watching this, they've got their wine or their cup of tea or their coffee. Now go over to our Cam Pro page and start learning how to be critical when looking at clinical papers. A lot of you guys will be buying stuff that say that they've got a number of references. We all fall for it. Tiny little black writing at the bottom. All these references, a lot of them mean nothing. So go and learn how.
Even the ones with the really big, impressive titles. Often the bigger the title, the less it says.
Yes, exactly. And the ones that just go, oh, and they've got 18 people that were involved. Yeah. There's a few tips and tricks that you can make yourself a little bit more savvy. You know, if it was done in 1979, starting point. Okay, so head over to the Cam Pro page. Let's say thank you very much to Karen. Thank you so much.
No worries at all.
See you later, guys.